Good morning and welcome to day 2 of the Home Health Quality Reporting Program. This is the agenda that will be covered today. Drug regimen review will be done by Kathy Roby from Qualidigm, who you heard from yesterday. Following that, there will be a case study that will be presented by Ann Olson, also from Qualidigm. And following lunch, Jen Pettis, I'll introduce before she speaks, will present data submission and reporting. There will also be time for questions and answers like yesterday. Here's the photos of today's speakers. As I mentioned, Kathy Roby will do drug regimen review. Jen Pettis is data submission and reporting. Her colleague, Julie Ellingson, will be virtually participating with her. Jen is the only one who will be in person today. This is the site that we mentioned yesterday, and thank you again for submitting your questions through this web page. If you're watching online, the top left corner, there's a link labeled Attention, and if you click that, you'll be directed to this same web page for submitting questions. As always, like when you use the microphones, and please do so today because of the large web audience, and when you submit questions on the index cards, please write your full name and organization with the question. If you can put the section, that's also very helpful. Here's where you'll type the question and then click Submit. We ask that you only enter one question per page. After you click the Submit button, you may click on that blue link to ask another question. At the end of yesterday, we reviewed some of the questions that had been submitted throughout the day. When we were finished, I had said that was the last question, but I'm sure, as you know, if you submitted one online, we weren't able to address all of them. So we're going to start out this morning reviewing some of the questions from yesterday that the faculty have had a chance to consider, some of which came in last night, and that will be done now by Ann Olson from Qualidigm.
So we did get several questions, as Mark mentioned, and just wanted to address some of them now. The first one, and I'm going to be addressing the GG questions. So the first question was, if the patient is not allowed to lay in a bed due to shoulder surgery, but instead sleeps in a recliner, would we use code 88 or assess them in the recliner? So yesterday we talked about this, and we discussed that if a patient does sleep in a different surface, whether that's a recliner or a mattress on the floor, that would be considered the patient's bed. So the answer to that question would be, if the patient's usual sleep surface is a recliner, the recliner can be considered their bed for GG 0170C. You would assess the patient's mobility in the recliner, treating the recliner as the patient's bed. The next question was, how would a patient with a BKA be coded to perform lying to sitting position with feet on the floor? And the answer to that was, if any patient can perform the activity independently and safely, sitting on the side of the bed with no back support and their feet do not touch the floor, they can be scored as a 6. We talked about that yesterday. So even if it's someone that is short and their feet don't touch the floor, they still could be scored a 6 if they required no assistance. So for a BKA patient, the score would be based on the amount of assistance required to complete the activity. And if the patient was able to complete the activity independently, moving from lying to sitting on the side of the bed with no back support, then the patient would still be scored as a 6. The next question is, where are the handouts for the mobility questions and will updates and recordings be posted? The handouts for the mobility section were located in folder 5. That was home health QRP provider training, pressure ulcers GG0170C. And the correct answers for the scenarios and the recordings of all the presentations will be posted on the CMS website. The next question was, they asked, could you please give the answers to the scenarios again? There was some feedback during the presentation that they wanted the answers to be posted again. We received that later, so it will be posted on the website, the PowerPoint presentations with all of the answers that we discussed yesterday. The next question, the agency admits a patient that was bedbound prior to this start of care, resumption of care. The nurse scores GG0170C1, rock sock. Performance score as 09, not applicable because the patient was bedbound. For discharge goal, GG0170C2, what is the appropriate score? If code 09 is not an option for GG0170C2, would the correct code to use be a dash? And the answer to that question was the appropriate code in that scenario would be to use the dash for GG0170C2. The next question, the patient can be assessed by report by the patient or caregiver/family. If the patient refuses to do the activity but verbally tells you what they are capable of doing, can you code 01 through 06, or do you have to code 07? And the answer to that would be is if the patient does refuse to do the activity, you would score them a 07. The next question, the patient can be assessed by, The next question is with GG0170C2, what is the discharge goal being used for? Parentheses, we don't usually use this in home care. Does this impact or increase the risk adjustment as a covariate for risk for pressure ulcer quality measure? Is it not included in the discharge assessment because we are not measuring improvement in mobility? And the answer to that is that the SOC-ROC performance score and the discharge goal score for GG0170C are consistent measures in all post-acute measurement tools, and it is used as a covariate to the percent of patients with pressure ulcers that are new or worsened quality measure. And I think that that's all the questions that we had consensus on. I'm just double checking here. Yep. So I think that's it. We do, as Mark said, have several other questions that we will be discussing, and we'll be getting back to you a little later today on that. Thank you so much.
Couple of brief announcements as we transition. If you're here today for the first time, restrooms are out the doors and to your right, and there are evaluations in the folders that were at your table yesterday, and we'd love if you could please complete those evaluations. We know CMS values the input and feedback that's received from participants, so staff in yellow shirts will be around at the end of the day to collect those evaluations. We're going to continue this theme and have more questions and answers that were submitted yesterday or last night with responses from Ann Spenard, also from Qualidigm.
Good morning, everyone. Let me just get a second here. We are going between databases to have the Q&A. All right. Let me get down to here. Skip down. So the question is, if we are supposed to assess the condition of the ulcer on admission, and it's now better than it was in the previous facility, why wouldn't we code it based on what we see instead of what it was instead of what we currently see? And hopefully you all clearly got the instructions yesterday that we don't reverse stage, that whatever the ulcer is, at its worst stage, it's that stage until it actually heals or closes. So I think that's probably going to be one of your biggest challenges with your clinical staff. And I've talked to people after the session yesterday and into the evening, and you're unique in the 4 healthcare post-acute environments, because in most of the brick and mortar settings, so the IRFs, the LTACs, and the SNFs, you have a couple of people who are assessing the wounds, right? So it's limited. When you think about the home care, all of your RNs that are going out and doing the assessments and the sock rocks and whatnot, you may have a huge workforce that you need to make sure understands what they're looking at and certainly understands this change. So I think, again, a nice opportunity for educating. Okay, we answered that one yesterday, so let me just go here. So the question was, we have a patient with, I'm going to try to, epidermolysis bullosa, which is basically that disease where they get all the blisters. I've seen a few of those in my career. The person says, I've been categorizing his blisters as open wounds as pressure ulcers. Is this correct? If not, what would I call them? Well, this is a disease process. So these ulcers, and you can get them kind of all over, even internally. And so, again, remember that caveat. You can only call it a pressure ulcer if one thing, right? One other caveat, it needs to have pressure involved in the process. So I'm not saying that a person with this diagnosis could never get a pressure ulcer, but the fact that all the blisters that they're getting are not related to pressure, that they have this disease process. So just hopefully that answers that question. So there was a question on one of the scenarios, on practice scenario 1, and this was hard. You probably need to pull out your practice scenarios to understand the answer to this, but M0 or M1311B1, do not understand why the answer would be 0 if it was a stage 2 and now is a stage 3. It was still there at the start of care unless I did not understand it. So what we're saying is at the start of care in this particular scenario, for this scenario, the patient had 3 stage 2 pressure ulcers, if you remember that one from yesterday, upon the sock. And 2 of the ulcers merged to become 1, and then the third ulcer increased in numeric stage. So in fact, when we're looking at it, the 2 of the stage 2 stayed at stage 2 but became 1 ulcer, okay? And then, so we would have said there, on discharge, there was 1 stage 2, and then the next question says, of the stage 2s, how many were present at the start of care? And we would say 1. The next question then was, how many stage 3s do we have at discharge? Well, in this scenario, we have 1, right? How many of the above stage 3 ulcers were present upon admission? 0, right? Because the patient, there were no stage 3s upon admission. They had ulcers, but one got worse, okay? So it wasn't present upon admission. So hopefully that clarifies that. Another question on reverse staging. No, we don't reverse stage. So that's a pretty simple answer. So there was some questions again around the term, and I would just want to clarify for everyone listening, we use the term coding, and we tried to do it to set the stage at each one of our presentations to say the term coding, when we're presenting through this conference, is around encoding or scoring the OASIS. It is not coding ICD-9, or ICD-10, sorry, dating myself a little bit there, ICD-10 coding. So scoring, coding, whatever, but the word that we're using is coding, but it doesn't mean the ICD-10 coding. So there was a question around that. And I think I have a couple more. Okay, the patient had a stage 4 right heel ulcer in the sniff. Patient was admitted to home care with a non-stageable right heel ulcer, and during home health episode, ulcer was debrided and now is a stage 3. On discharge, is it a stage 3 or a stage 4? And the answer would be a stage 4, correct. A wound would be staged at a 4. A pressure ulcer documented as a stage 4 will remain a stage 4 until closed. So, obviously, again, you know, this is not the easiest stuff to do, but the fact that we had so many questions around reverse staging, observation of what you see versus what is clearly documented clinically and brought forward, I think what it's telling me is a great opportunity for education for your staff. Those are the questions that I was able to get last night. We have a bunch more questions that came in. We'll be working on those, and we will do another Q&A. I think it's at the end of the day. And we hope to get all of these, and then these will be posted. These Q&As will be posted, so you'll have them, and you can pull them down and look at the answers. So I appreciate all the great questions. Continue to have them come in, because if you have the questions, someone else has that question. So we appreciate it.